All right, welcome back to the Mint Condition Podcast. Today I've got a guest, Dr. Jake Ereckson. He's with First Care Medical Physical Therapy. Am I saying that right?
That's correct.
Okay.
Yes.
It's a long name.
It is. There's more. We're subsidiaries and owned by blah, blah, blah.
When the receptionists answer the phone, do they say First Care Medical Physical Therapy?
I think most of the time they just smack their forehead and sigh a little bit.
That's great. So Dr. Ereckson has been doing PI, auto accident injury, almost your whole career. You've been a physical therapist for 16 years.
Yes.
And in the auto accident specific industry, working with some other things too, right? Some cash pay patients, maybe a little workers' comp, but for 14 years. So you've got a lot of experience.
Yeah, that's right. Opened up my first kind of private clinic with the help of some investors back in November of 2011. So yeah, 14 years ago. And pretty quickly found our niche working with personal injury and auto cases for the most part. Initially, we did see a lot of health insurance patients, but as regulations tightened and deductibles and stuff went up, it became a lot harder for us to keep and manage those patients. So we found, just from a purely business perspective, that auto accident or personal injury cases were kind of an untapped market, because when I first started doing auto cases, I don't really think there was anybody in Salt Lake or in Utah that was really seeing as much as I was. I knew that
Physical therapist specific?
Yes, physical therapy specific. I knew of a few of the bigger companies and stuff that were starting to take a few auto cases, but a lot of times they had regulations that I didn't necessarily agree with. Like they would have a patient, pay basically a copay to be able to see them, even though they were going to get paid more on the back end, which didn't really sit right with me. And then, other things as far as, I know of one clinic that would only see personal injury or auto cases if they were involved in the initial part of the case where they got the immediate PIP money.
Yeah, the PIP money.
Which also, to me, just doesn't seem fair. I'm very much a person who I like to give, and I like to make sure people have the care they need, even if it's sometimes to my own detriment a little bit.
Yeah, it's common in physical therapy, nurses, medical in general, is a lot of that bleeding heart mentality, right? Mm-hmm. But I think that's great that you guys found that niche and so long ago. But even today, how many physical therapists do you know that are doing this?
I mean, a few people have started to pick up the odd case here and there. I still don't know of anybody who has ever gotten to the numbers in personal injury that I've been doing. 95% or so of my caseload for the past probably 10 years has been auto.
Yeah, unheard of.
With the other, 5-10% being strictly cash pay. So.
How do you see that being important in our landscape, where most people in a car crash, from what you've seen, just chiropractors, or who are they just working with, and why do you see physical therapy being important?
So that's a complex question.
Yep.
So as far as, well, let's just talk the business aspect first, right? And then we can talk about patient care. But, when you're dealing with a personal injury case, I was talking to an attorney recently, and we were just talking about how, 7, 8, 10 years ago, you would get these astronomical bills that came from just one provider, usually being on the chiropractic end, because there were more chiropractors doing personal injury than anyone else. And so in the defense of that profession, like, if nobody else is taking the payment method of your patient, how are you going to refer them out? Right. So it was a difficult situation. So when we started doing it and and working with different attorneys, they found that it actually strengthened the case, just again from a business aspect. So $10,000 in just chiro bills, or I would, as an example, even turn that around and say $10,000 alone in PT bills with no other bills that come into that is a much worse case than the same amount of money but split between physical therapy and chiropractic. Now, when we look at that from a patient care perspective, I'm a very empathetic person.
Yeah.
And so I know that if I was going to see anybody for rehabilitation for more than, if it was a surgery, maybe a little longer, but more than, 3 to 4 months, I'd probably start to get frustrated if I wasn't feeling quite a bit better. Now, if I'm steadily improving, that's a different story.
Right.
But if you're plateauing at 3 to 4 months, why would I want to continue for another 3 to 4 months? Yep. And so from a patient care perspective, it's nice to get another viewpoint on that. And I would say, I know that there is or has been traditionally a little bit of animosity between our profession and the chiropractic profession.
Yep.
But if I'm not having success with somebody, I would love to have another perspective. And oftentimes that would be, a chiropractor or somebody that is traditionally quote unquote competition to physical therapy.
Right.
I think it's worth mentioning as well that my current company, we have a chiropractic division. So I work very closely with them. But.
Yeah. Well, you look back on PT school and I don't know about your school. Mine brainwashed me a little bit against chiropractors, right? Mm-hmm. And I got out into practice and quickly referred to a chiropractor for a patient, despite being told that all of them just want to take patients' money, right? Mm-hmm. And that they aren't trained clinically as well, or whatever I was told before. And my first employer was not happy with me for referring to a chiropractor. Mm-hmm. And the patient had great success. It sped up her recovery by at least a month or more by working together with them. And so I was like, I don't know why we have this bias.
Yeah.
And there are going to be some bad chiropractors, right? Ones that are just pushing things patients don't need. There's bad physical therapists who put patients in a box.
Yeah. That's essentially what I tell all of my patients, and that's what I encourage the general public to do is to find somebody who's good. It doesn't really matter necessarily what their profession is. If it's somebody you trust and that they're good at their job and it's something that you believe in as a patient, you should do that. Right. Placebo and nocebo those effects are very, very real. And I think in medicine, sometimes we should take advantage of that.
Well, we absolutely should. We could have an hour-long conversation just on this topic multiple times. Patient, especially earlier in my career, maybe I have more confidence now, but early in my career, patients would look to the receptionist. I'd be like, hey, we're going to do this. This is going to help here. Let me teach you the science behind it. And they'd be like, check with the receptionist. And she's like, yes, do it. And they're like, okay, good. Yeah, let's go. It's just this, like, getting that affirmation, this is the right treatment. And your confidence as a provider, your patient's confidence in you, or maybe they've had that treatment before. One of my favorite things from James Dunning's class is when I think it was his class, where they show the little stick figures, whatever, having this conversation, and this patient says, ultrasound really helped last time. And the PT's like, well, according to the research, I have to do it with 9 other people before it will work with you.
Yeah.
And
I think that was probably a Nate Henry, but through the Dunning Institute.
Yeah,
but
that's
that
right.
sounds
It
like
was
something
Nate.
He would have. I mean, I've seen a lot of his lectures as well. But yeah, I do think, just to kind of take a small tangent and we can return, but when you're, oh shoot, I just lost my train of thought.
James Dunning, Dunning Institute.
No, we're talking about the placebo effects. Oh yeah, what I was going to say is that the fact of the matter is there's a lot of overlap between our professions.
Yeah.
When you're on the surface, you talk about modalities and stuff like that, but as you dive deeper, some of the things that I practice a lot, with spinal manipulation being very similar to chiropractic adjustment, with dry needling being very similar to acupuncture. There are chiropractors who do both of those things.
Right.
And I think we need to get away from fighting each other on the inside and realize that sometimes there's somebody who's better than you at a certain thing. And in the interest of our patient, we should send our patients there. And I think you can extend that to even surgical stuff, right?
Right.
I think we
should start doing surgery.
Exactly.
No, I'm just kidding.
No, there needs to be a bigger shift towards working as a team in medicine, even if it's something that you don't necessarily think is. I mean, we always want to do what's best for our patient,
Right.
but a lot of times we get skeptical about things that we don't know about. And this is going to transition into a whole other topic, but
It's an important one though.
yeah,
Because if we don't know about it, we're failing our patients by not knowing, right?
Right.
Like I was anti-acupuncture at first when I first graduated, not because anybody brainwashed me. It was my own, I guess, perception,
stigma.
It was my fault for not going out and acquiring more information. I've talked with PTs who are like, dry needling does nothing. And it's like, oh, cool. How many courses have you done? None. Why would I waste my time?
Exactly.
And they're failing their patients because it's an amazing treatment.
Yeah. And then we fall into traps as well. One of the big things in the physical therapy world is that spinal manipulation, especially when we're dealing with cervical and upper cervical manipulation. There's this huge stigma that it's dangerous.
Right.
And when you look, and I think all of us were taught that in school, our professors thought that and taught that. But when you look at all of the evidence on that, it's just not there.
Yep.
Certainly it's possible to hurt somebody doing that. But when you look at our profession as a whole, one of the examples that I'll use is just as many people, or well, definitely more people actually probably get hurt from walking their patient down the hall in the hospital or something. There's something, if you do any of the treatments we do completely wrong, there's a chance you might hurt somebody.
Right.
But if you're doing them correctly and in the right situation with proper screening, it's really not anything to be scared of. And to that point, I think that fear is a huge part of why our profession can stagnate at times. Because, you've been told or you think that manipulation of the cervical spine might kill somebody, you never bother to learn anything about it other than what you already know.
Right.
And same thing with dry needling, because it's so acupuncture adjacent. There's people not understanding the traditional Chinese medicine because it's not part of our curriculum over here, and so they just poo-poo it because they don't know about it or don't believe it. But that doesn't change the mounting and ever mounting amounts of research that are out there on the topic.
Yeah. Anybody who I've had disagreements online with about dry needling or whatever, I'll pull up research and they're like, well, if that's from James Dunning, then it doesn't count. I'm like, what?
He does the same IRBs as everybody else.
Like you can't just say this whole category doesn't count because it doesn't support my belief.
Yeah, or because it's, and not to get into politics at all, but it's the same way with society and life in general. If somebody doesn't agree with you, or somebody doesn't understand your standpoint, they'll believe it's invalid
and unethical or immoral.
Right.
You're an evil person because you believe. It's like, how about you look into the things behind it?
Yeah, and I'm I fancy myself an educator, and so I love to look deeper into the research. And honestly, the way people even use the term research really bothers me nowadays.
Yeah.
But just to go back to the topic of being scared of what you don't understand. It's I have often said and thought about my personal career doing personal injury, when nobody else was doing it, and I truly believe that a big reason that a lot of these bigger companies, back when I first started my clinic, the reason they weren't doing it is because they didn't understand it, or
Yeah.
they were afraid that their notes were going to get read by attorneys and they'd somehow get in trouble for, you know, lying under oath or something like
hopefully
that.
not that far,
And
but
hopefully you're not feeling that way, but that's the truth. You know, they're scared of not getting paid, or
right.
they're scared that you know, they may somehow get in trouble, and that fear of getting in trouble is
Well, and
what
their
keeps them
fear
from
of
doing it.
right, and fear of being deposed. And I had some of that early on, and went and took some classes on it. I'm like, this isn't scary, and they give you a lot of confidence. They're like, you are the expert. What before?
That's why you're there.
Right, exactly. So before it was like, well, patient has this because I said so. Felt weird. Like when you first graduate, everybody talks imposter syndrome, right? It's like, no, yes, because you said so. You went and studied, so you know the research, you know, you have the education and background. So because you said so, because you're that expert.
Yeah, and that's another thing as well. Like I have been thinking a lot in my personal life as well as in my career about the Dunning-Kruger effect, right? And that very much plays a role in physical therapy, and I think any medical profession. Like you come out of school, and it ties right back into what we were just talking about. You come out of school, and you are armed with all of this knowledge. You know, you performed well during your clinical rotations and things like that, and you come out and start working, and you're like, I'm a fake. I'm an imposter.
Yep.
But initially, before you hit that point, the valley of despair is what they call it, and the Dunning-Kruger effect. You're on the top of, what is it? Top of Mount. That's a funny name. Anyway, but people come out of school being confident. Then you have that dip, and then the trick is after that to keep on the educational slope that makes you an expert in your field.
Yep.
It's very easy to stagnate anywhere along the line. You get doing a few treatments that you think are effective, and you know think you're the smartest PT at some point. And
I
if
went
you
through that,
yeah,
and then I found out I wasn't.
exactly. And then if you sit on that, that's where your plateau is.
Yeah.
If you sit on that, that's where your plateau is. But if you don't, if you continue to be introspective, then you can actually be the expert that you thought you would be coming out of school. And I'll be 100% honest with you. Like, I wasn't completely comfortable in an evaluation for probably 2 years out of school.
Yep.
And then after that, I was comfortable. I mean, I did a good job. I would gather all the evidence. I would then go to my books or the internet and double check everything I was doing. But I made it a point in my career to, if there was something that I wasn't very good at treating or didn't know a lot about, I need to take a course on that. And if the course isn't convincing to me, I can set that aside, but at least I know about it. Right. And when a patient comes in and wants to talk to me about that treatment, I know enough about it where I can give them an education saying, yeah, it might help with this, it might help with that, or, you know, it might not be the best for your case, or it might be, but I'm not great at that. So you may need to go to another provider to get that help.
And I think that's the humility. Once you get past that plateau of I'm the best PT in the world, you get past that, you find out you know how much you don't know, or you start to learn how much. You actually start to serve people better. All the time I tell people, here's my stance, here's what I've learned. I recommend you get at least one or two more opinions on this, because you start to realize physical therapy isn't the end all be all. We're pretty awesome, right? Research shows that we reduce medical costs, that we get people better, that we avoid the more aggressive treatments. It's really, really good. Not the end all be all. I've talked with physiatrists that I'm just like blown away how smart they are. Brad Duhan is a surgeon out of Colorado. I was just like eating up his words. It was so just inspiring when you're like, man, let's keep learning.
Yeah. Oh, I think I mean, if there's one thing I ever teach my interns that come through the door, or back when I was teaching at Provo College, it's that you need to continue learning. Be introspective, figure out the things that you're not good at, keep going with that, and then find out as much as you can about other professions. Like, for example, I'm not a medical doctor or an injectionist, but I can certainly talk to you all day about the different types of injections and what might be a better case for you, or a better scenario for you moving forward. And then I encourage people, go get that injection consult, go get that surgical consult. That doesn't mean you have to do it.
Right.
But knowing that it's an option, if the conservative treatments and measures don't get you all the way there, can put your mind at ease that, if you're not getting better, there is another route we can take. But I mean, again, back to the business side, it can also strengthen a case.
Yeah.
If we have other professionals talking about the severity of a person's injury, doesn't mean they necessarily have to go through with the treatment. It just...
Well, what would your advice be then for chiropractors? Because I have found, obviously, it makes it stronger when we've got MRIs. We've got several doctors on the case. Mm-hmm. There are chiropractors out there who don't refer to PT at all. Mm-hmm. Whether they're afraid we'll steal their money or steal their clients, or they just don't see the value because they haven't experienced it. Mm-hmm. What would your advice be to those chiropractors so that they can start working as part of this team?
I think it's very important, and the thing that I've done over my career has been to actually just have them sit down and talk with somebody who is a good physical therapist that understands the nature of the personal injury game and the way things work and how to add value and stuff to cases. Another thing, and I think that when medical professionals actually interact and get to know each other better, you tend to trust the people around you more. But again, that fear, if you're a chiropractor and you've never talked to a physical therapist, or if you're a physical therapist and you've never gone and had lunch with a chiropractor, then you're kind of missing the game, and you're not doing the best thing for your patients if you're
right.
not fully understanding the other professions. I think another thing that I would personally tell a lot of chiropractors is, and it's not just with chiropractors, there's acupuncture lobbyists and stuff like that don't really love that physical therapists do dry needling, or chiropractors that don't love that we do manipulation. And I lost my train of thought again.
The advice you would give?
Oh yeah, one of the things that I would say is, it's also a really good continuum of care. If a patient has been going to a chiropractor, they've been seeing improvements, but kind of plateau. If that chiropractor can send to a physical therapist that can do manipulations, you have that continuum of care without making that patient drive from place to place. Right. And same with acupuncture, right? If somebody is plateauing in the acupuncture field, maybe they need a slightly different approach to it. Right. Go a little bit deeper, maybe use a little thicker needle, or go with an established protocol that is away from just the meridians and stuff like that. Right. Which I hope everybody understands that I would never disparage anybody else's career. Right. I think we all have a place, and that's exactly what I'm trying to say, is that just because our professions overlap a little bit doesn't mean you have to be intimidated by what we can do. You can use that overlap to make the patient's transition more comfortable and get them a little bit of a different perspective.
The way I like to explain it to people is kind of like music, where they might not like my style of music, my art, right? Or maybe their body's not responding well to it. Mm. So even within the one profession, acupuncturist to acupuncturist, or chiro to chiro, PT, I'll send my patients to other PTs when what I'm doing is not working, right? I have no problem sending them out to chiropractors, acupuncturists, whatever seems like might be worth at least an assessment, right? But even just, you got to realize people respond differently. I've had patients who are like, this was too aggressive, and I've had other ones who are like, you need to go a little more aggressive on the exact same treatment.
No, that's a great point too, because that's another one of kind of my standard conversations that I have with patients during their initial evaluation. At my main clinic, the place where I've been now for 16 years, I have several PTAs. I've had PTs that come in over the years. There's almost always interns there. And so a conversation I have in that evaluation room on that first visit is when you come in, you may be seeing another one of our providers. If you would rather just stick with one person, that's totally fine. We get that. Otherwise, I kind of like having several different sets of eyes on you.
Yep.
Not only that, but we all know the same treatments. We all read the same documents on you, but we all do have slightly different styles of physical therapy. And so I tell my patients, if you find a style that seems to work best for you, request that person. But otherwise, let's get as many eyes on you as possible.
Yeah.
Because as good as you and I are, Brad, sometimes we miss things.
Well, we are the best. We just can't treat everybody, right?
Right.
That's why we need everybody else. I'm just kidding. No, that's
Cut that part out.
Right. Right. No, that I completely agree with you, and it has been humbling to learn over the years how much I don't know, and exciting too. It's a lot of fun.
Yeah, I mean, I think it's great to have professionals that are that way, that are interested in learning and growing and making our profession better. Yeah, it's. I mean, I'm like I said, 16 years into my career, and shoot, I mean, granted, I've hosted and assisted courses for a really long time.
You've done a ton of that.
But I've probably gone through dry needling certification. Obviously, I only needed it to do it once, but sat through the classes probably 15 times.
Yeah.
Something like that.
Well, especially if it's something like dry needling, spinal adjustments, you've got to do the courses over and over, stay fresh on it, and there's some muscle memory and repetition that comes along with that.
And there's also, again, when you see different instructors or new developments happen in the field, those courses are the places you want to go. I mean, in good courses, there are plenty of, just like there are plenty of good and bad PTs and chiros and doctors and whatever. There are good and bad courses. So
for sure.
But if you find something that's a good one and can continue it, there's new information every time you go, or even if it's not necessarily new information in the presentations, you'll probably pick up on something new every time. And it's funny that you mentioned like the dry needling or spinal manipulation institute and people not liking the research that comes from them. And it's people just not liking research or evidence that doesn't fit their narrative.
And it's a minority, right? It's one or two people with strong opinions. And it's usually, what's that term? When somebody has a strong opinion despite or due to the fact they just don't have any ignorance.
Ignorance.
Arrogance, right? So I love the research. I go through a ton of it, and it's very inspiring to read and also helps you think clinically when you're applying these techniques.
Yeah. Like you said, I'm a research geek, and I do love being able to break research down and talk to people about misconceptions. And like when I have students often or interns that come to me and ask me why I do a certain treatment or why I don't do a certain treatment or a certain test. And the first thing I tell them is, whether or not I agree with them, the first thing I tell them is, show me the research. Tell me why I should be doing that or why I shouldn't be doing that.
Right.
And once we get the research, you have to, please everybody out there, you have to do more than just read the abstract.
Yep.
You can't just read the conclusions.
Yep.
Because if you look at most of the methods in things that have become just a staple of physical therapy, there are gaping holes
Yep.
in that research. And whether it's because the researcher didn't think about certain things or intentionally left things out, it's important to be able to discern those things, to decide which research is not only out there, but what research is good.
Yeah. We're all human, and we have that innate bias, right? The best researchers try to prove their bias wrong, right? They're not trying to prove their bias right, because then they usually will find that.
That's another good Dunning quote, James Dunning, where he says that you don't do research to get a no, or what does he say? You don't do research in order to get inconclusive results.
Yeah.
You want it to point to one thing or the other.
Yeah. Yeah.
And that's how you get things published.
Yeah.
And that's helpful, but it can be dangerous as well.
Well, when something is 90% effective or effective for 90% of people, statistically, it's not helpful.
Yeah.
It's like, but 90% is pretty dang good.
Yeah.
You know?
And there's also the topics of effect size, right?
Yep.
You can say, for example, that, certain, I don't want to turn people off to what I'm saying, but there are certain techniques that are common practice in physical therapy that have been shown to be effective, but the effect size is like 1.8 on the visual analog scale or something like that.
Yeah.
And so you can do a treatment that will bring your patient's pain down 2 points, well established. Or if you look at other different treatment options, you can see something that may be on the fringe, but it's a 4-point difference in your visual analog scale or Likert scale or any of those different perceived scales.
I don't know why, but that just reminded me of something I need to ask you about. So I have this perception, and I've been working with people in auto accidents for 3 years. So basically the same as you, right?
Pretty much.
But if you are working with someone who is in a car crash and we don't maybe give them enough care or the right kind of care or whatever, are you finding that 2 years later they're having problems? Or maybe you're not in contact with the patients at that point, but that's the perception I currently have, is that they're going to have rebound issues.
Certainly that happens. One thing I do is to make sure my patients know that, once they're discharged from physical therapy, it doesn't mean they can't ever come back.
Right.
And when you're dealing with spinal injury, especially if there's ligament injury or disc injury, there is a good chance that they may have flare-ups in the future. The goal is to get people confident enough in their own self-management skills to be able to, once they feel a flare-up coming on, that they can calm it down without needing other intervention. But I also do have an extremely reasonable private pay rate, and my door is always open for consults, free consults for people who I've seen before, but they had an issue come up with it.
How common is that?
I would say it's not very common, though.
Okay.
I do have a couple patients that are pretty much lifers. Once a month they'll come in, but those are usually just they want to come in once a month for a manipulation or a dry needling session or something, and it's a 1 or 2 visit and done type thing.
Okay.
We usually don't have to. I can say probably in the past 10 years I've had maybe one patient a year that comes back for a full new round of treatment because everything returned.
Yeah.
But
still very impactful for that individual.
Right. Absolutely. But when you compare that to the 20 new patients a week that come through the door,
that's pretty good.
At certain times, that once a year is not too bad.
Yeah, not bad at all. So we've talked a lot about providers, the whole concept of working with people in car crashes. What would you tell the people? Somebody's in a car crash. What would you tell them? What's your advice? Which providers to go see? Should they get a lawyer or not?
Well, obviously, you should come see well, Brad apparently we established was the expert.
Right.
But no, come see. I would say go see whoever you are the most comfortable with.
Okay.
And I think most people have enough body intelligence to be able to say, this is something severe. I need medical intervention. So at that point, go to the hospital, urgent care, or a doctor that does personal injury if it's less of an emergent situation.
Right.
If you're more comfortable with chiropractic, go to chiropractic. If you're more comfortable with PT, go to PT. Just be aware that if you go to any of those people, be open to going and getting consults from the other specialties as well.
Yeah.
So I think that's my biggest advice is just know that where you start isn't necessarily where it's going to end. But you also do have choices in your recommendations. Don't let anybody tell you that you can't go see a medical doctor first, or a physical therapist first, or a chiropractor first.
You can go walk into any of those doors. What I like that you said, go see who you're comfortable with, and then the second part, see multiple people. So if you're really comfortable with your chiropractor, that's fantastic. And if he or she happens to not be one who recommends other people, then advocate for yourself. Go and also get at least a consult and evaluation. With the practice I work in, we'll see patients just for an evaluation and keep doing what you're doing. Just get a second opinion and, send them on their way, support the case or whatever.
That's exactly right. And, when a patient comes in to see me, I will always tell them that, yes, I am an expert in anatomy, physiology, pathology, things like that. But you're the expert in you. And so
I like the way you word that. That's good.
yeah. And so, forgive the idiom, but the term "there are several ways to skin a cat" is
true.
disgusting, but it's true. Like, for any given pathology that I see in physical therapy, there are probably 5, 6, 10 different ways to treat the same issue. I'm going to use the one that I think will probably work best for you, or the one that I've had the most success with.
Yep.
But if that is not working for your personal physiology, you need to let me know, because while I can see changes in testing, strength, range of motion, I can't feel your pain. And so I need that communication.
Well, and you're not with them 24/7 either, right?
Yeah. And I would warn patients against just saying, well, you're the doctor. I'm going to do what you tell me to do.
I hate when they say that.
Yeah. And that's where I usually bring out the "you're the expert in you" type thing. Because everybody does respond a little bit differently.
And I think it's important. Patients want to trust us, right? And we're in that position of authority of sorts, right? You need to know what you're doing well enough to build confidence for your patient, but then inspire them and encourage, educate them to advocate for themselves and do that.
No, I think that's a great point. And I can't tell you how many times over the years that a patient will come in, they'll talk to my front desk staff, and my front desk will always, we've learned over the years to ask the patients as they walk in the door how they're feeling. Not only because it gives us a direction in how we're going to take treatment for that day, but also because sometimes, as you said before, the patient is more comfortable talking to a front desk or a tech than they are in talking to the provider. And it's kind of weird. It's almost like they don't want to hurt our feelings. It's because, they'll come in and tell the front desk, oh man, I'm hurting today. Will the provider, PT, PTA, intern will go over and see him and ask him, how you feeling? And the patient is like, oh, I'm feeling pretty good. Like, they don't want to let us know that they're plateauing or something like that. And then after the visit, they'll go in and talk, or, the attorney or paralegal will contact them to update the case. And get an idea of when they can start closing and all that stuff. They'll ask the patient how they're feeling, and they're like, I feel awful. So like
but the PT note says that they're doing amazing.
Right. So we have 3 different opinions, and while they're maybe trying to, like I said, spare our feelings as providers, in the end, it may hurt their case.
Yeah.
We had one recently where it wasn't a PT patient, but it was somebody that was seeing one of our chiropractors, and every visit, in the subjective portion, the chiropractor would write, patient is feeling better today. They left out like better is comparative.
Right.
Right.
They had 3 bad days, then now they're better today. And 3 bad days.
Or, better than they were on day 1.
Yep.
But haven't
only
changed in a
2%
week.
better. Yeah, exactly.
And so yeah, they need to be a little bit more, the patients need to be a little bit more honest and proactive in telling us how they actually feel. And the providers also need to probably dig a little bit deeper. But that case I was talking about, it really hurt their case when those notes were submitted to the insurance company.
Yep.
Because, 10 visits of patient is feeling better, patient feels better, patient feels good. Like, why are they going?
Yeah.
Yeah.
So one last piece of advice for patients out there, people who are in a car crash, should they get a lawyer?
Yes. It doesn't always have to be immediate. It doesn't have to be in your first 10 days or 2 weeks. And sometimes, if you feel like your injuries are minor,
right,
you can seek out providers and get some medical treatment for that, depending on what your insurance is, that first $3,000 to $5,000 of PIP money.
Yep.
And then if it doesn't look like conservative management is going as quickly, as you leave the subacute or the acute phase of healing, if it doesn't feel like things are getting a lot better, then at that point it's probably worth it. Or if the insurance company gives you any hassle at all.
Yeah.
If they don't want to pay out the PIP, or if they don't want to, if they call you and tell you that you need to close your case or there's not enough property damage, then in those cases you need to get an attorney. That's the only way they're going to pay. And the attorneys are important, especially if you are missing work or school, or if you're not able to perform your normal activities. That is costing you out-of-pocket money that might not be seen by the insurance companies. You need to make sure the attorney's involved if it's more than just medical care that you're missing out on.
Well, and document all of that. Get
Absolutely.
A journal of everything. How many miles did you drive? Like, as much documentation as possible. What I like in the auto accident world is a lot of the attorneys will do a free consultation. Mm-hmm. And I always encourage people to interview several attorneys, just like they should interview several PTs and find out who's singing the music that resonates with them.
Yeah.
So,
and just an interesting note on that is, my girlfriend Chelsea, if you're listening, turn it off right now. But I dated a girl a while ago that was in a car accident, and she ended up calling an attorney. I won't mention which attorney it is. But she went and talked to an attorney, and the attorney during that free consult said, well, just let this play out. Like, continue your medical care, see what you can do. And, she spent a little bit more than the PIP in medical care. Like, at the time it was $3,000, and I think she spent like $4,000. Was feeling mostly better, and then the insurance company ended up paying her out like $5,000 or so on top of that. Now that's something that's usually not necessarily worth the attorney's time. It's not worth the patient's hassle in doing that if the injuries are relatively minor. But it just speaks to, talk to an attorney or two and get their opinion as to whether it's something that you may need help with or you don't. And I would venture to say that most attorneys out there would be very honest with you, because they don't want to waste their time either on something that they might not be needed for.
Yeah.
So
That's really good advice. So how do people contact you whether they're in a car crash or they just need a consultation? What's the best way to reach out?
So you can Google me, Jake Ereckson, and it'll show you the different practices where I am. Erekson.
Yeah. I got that wrong a couple times.
Yeah. You can contact my office. The phone number is 385-350-2971, or email me. And that's honestly, if you want to talk to me or get my opinion specifically, emailing me is the best way to go. And that's Jacob, Jacob, at firstcaremeds, plural, .com.
Cool.
Or you can send up the bat signal. I also respond to the bat signal.
Perfect. Yeah, I need to use that more often. All right, last question. I ask everybody this question. Our podcast is called The Mint Condition. So what does mint condition mean to you?
Geez, mint condition. That's a tough question. Honestly, and I feel like I should relate this to like healthcare and physical therapy, but I don't think I'm going to. I'm going to relate it more to mental health, I would say. So to me, mint condition is being comfortable and present in the moment. That state of meditation or prayer or whatever it is you do in your quiet time where you can just be. And if you can just be, to me, that's mint condition.
I love that. A very genuine answer. Thank you. Thanks for taking so much time to share your knowledge. I think I don't know if there's any other PTs with as much experience in car crashes as you. So I think people need to know that you're a resource and be able to reach out. So thank you.
You're welcome.